All right. It looks like people are trickling in. We'll go ahead and get started today. So we're very lucky to have our two guest speakers as part of our roundtable today. Our format's going to be a little bit different. So first of all, I'll just introduce myself. I'm Dr. Daniel Lee. I'm going to be the moderator for today. And for today's HIV and global health rounds, our topic is going to be about synergies and tensions between clinical care and research, the Owen Clinic history, and including in our discussion today are Dr. Chris Mathews and Dr. Alan McCutchan. And both have done a lot, certainly for the Owen Clinic, and their bio very briefly is listed here, but for both of them, they have very extensive bios, which I will not go into today, but very briefly, Dr. Chris Mathews is currently a professor of clinical medicine and Emeritus at UCSD at the Owen Clinic. He's part of the Division of Infectious Diseases and Global Public Health. Dr. Alan McCutchan is also a professor of medicine and active emeritus, also in the Division of Infectious Diseases and Global Public Health. And so today's session is going to be moderated by myself. There are 4 overarching themes for discussion. We're going to talk about the early challenges in establishing the Owen Clinic and UCSD as a focus of HIV healthcare. We'll talk a lot about, I think, the challenges in early patient management, and also about the role of the Owen Clinic in regards to developing clinical and basic research here at UCSD. And also we'll touch on the effect of both of these, I guess, HIV epidemic and the COVID-19 pandemic on clinicians, researchers, and the public. So for this session, we do ask that you please type in the chat pod questions that you may have, or you can certainly use your raise hand icon. And I think after each of these topics, we can take a brief second just to see if there are questions. And then there is a session at the end. We can take more questions at the very end. So there was actually a question before those 4 questions that we just came up with. And the first question I'll pose to both of them is, what were your first memories about the new HIV epidemic, even before you knew what was going on? So I think I'll start with Chris first on this question, and then we'll move on to Alan. So Chris, what were your initial thoughts and memories about what was happening?
Okay, thanks. Before I answer that, I just want to call to everybody's attention that this year is the 40th anniversary of the Owen Clinic. It was established in 1982. And my first awareness of the AIDS epidemic was in June of 1981, when the first MMWR came out announcing outbreaks of pneumocystis pneumonia and Kaposi sarcoma in gay men. And that same weekend, I was in San Francisco for a meeting of the Bay Area Physicians for Human Rights, which was the first gay doctors group in the United States. And because this announcement had just been made, they hurriedly brought out from NYU a dermatologist who'd seen the initial cases of Kaposi's. And I was in this room with 300 other gay and lesbian, back then we didn't have the word transgender, physicians, and we were just looking at one another completely baffled, because it was Gay Pride weekend, a time for great celebration. And of course, then we went back to San Diego, and I was in the late stages of working with a hospital to open the Owen Clinic, not as an AIDS clinic, because AIDS wasn't really well established at that point, but as a primary care clinic for LGBT people. So those were my first memories.
Alan?
Yes, I read the same article in 1981 in the summer while I was finishing a 2-year stint in London, getting a master's in epidemiology and then working at a sexually transmitted disease clinic that reflected some of my earlier interests in the gonococcus and lab studies I'd done with it. And I came back to do a month-long attending stint, and a patient who had been admitted in October with pneumocystis, as far as I can tell, the first patient in San Diego, was admitted and had a very complex set of symptoms and was terribly ill and died rather rapidly before we could really figure out what was going on with him. He ended up at autopsy to have just multiple disseminated opportunistic infections, including Cryptococcus and Toxo and MAI and very bad CMV throughout his gut. So this was like nothing I had ever seen before, nor had the pathologists. And we created a slide set. I went back to London and kind of convened a meeting of a wide group of people who were interested in this. Lab scientists working on hepatitis, STD clinic directors, and public health people, and the laboratory people, and so on. And I just presented this case, and I said, they had already seen a few people with Kaposi's, and I said, this is kind of an extreme endpoint for this disease with this total collapse of host defenses. And they were so impressed, they seemed to immediately spring into action, and with their much better developed and consolidated healthcare reporting system, they were able to quickly report from the laboratories and clinical sites any cases that looked like that. So I came back then and found that Chris was interested in starting this clinic, and I wanted to work with them for several reasons, but among them that I was interested in STDs and then this new entity. And so I got involved then in June of '82 with the Owen Clinic as it started.
Great. Thanks for those reflections. So I think the first question we were going to tackle and is really about what kinds of challenges that both of you had in regards to, I think, the early epidemic in terms of establishing both the clinic, but also having UCSD as a focus of care. And so these are several questions that I think I can let both of you just kind of decide how you want to talk about these. But for the audience, these are the questions. So can you describe the initial responses of the UCSD faculty and hospital administration to the HIV epidemic? What were the levels of fear of contagion and refusal to provide care? Because certainly we know that there are those stories. And what challenges and problems did you have with starting Owen Clinic? And then lastly, what were some of the similarities and differences between what's going on now with the COVID pandemic and HIV? So this one, I'll start with Alan.
Sure. I think that immediately people realized that this was a contagious disease, but it was pretty easy to compartmentalize it and say it's a disease of gay men and so on and so forth. So I don't think there was a an immediate response as a kind of cumulative recognition as new and other high-risk groups were identified, drug users, Haitians, and people who had transfusions and so on. And the level of anxiety got higher and higher, and there was a great deal of fear of contagion, I think mixed with homophobia, that really made it, difficult for everybody from the faculty to the janitorial staff to kind of put this in some kind of perspective. But mostly, I think people did their job. I think we certainly had, though, a lot of, people kind of leaving trays of food at the door, refusing to go in, that kind of thing. And that was true throughout the country and as far as I can tell, the world.
Chris?
Yeah, well, I won't go into the history of the initial starting of the clinic much, because I've told it many times. If there are questions at the end, we can go back to it. But just suffice it to say that the hospital and the department were actually supportive of starting a primary care clinic for gay and lesbian and people. The issue was what to call it, and that's another long story. But I wanted to just read a short excerpt from Barbara Peabody's book, The Screaming Room, about the very earliest days of the Owen Clinic, where we were meeting in the evenings 2 nights a week, Tuesday and Thursday, in the family medicine clinic in a building that no longer exists. And everybody was volunteering. There were no salaried people there except the nurses and support staff. So this is an excerpt about Barbara and her son Peter's first visit to the Owen Clinic. We were both anxious to find a doctor as soon as possible should problems arise. Owen Clinic, the clinic I found out about for the treatment of homosexual health problems, seems to be the best place for Peter. They've treated most of the local AIDS cases, and their doctors conduct AIDS research. The clinic is open on Tuesday and Thursday evenings in the outpatient department at UCSD Medical Center. Peter's first appointment was last night. The examination went well. The doctor, an affable type, spent over an hour with Peter, examining him completely, taking blood for the lab and sending him downstairs for a chest X-ray. He was a young, blonde, bearded, and wore sandals. Peter liked his unhurried but thorough manner. A California doctor, he laughed. He'd never survive in New York. They'd never let him take so much time with the patient, not to mention wear sandals. That doctor was a family medicine faculty member who, gay doctor who had volunteered to help us out in those early days. And he was a delightful person. I'm sure Alan will remember when you came back from England, how in those early clinic months, I think maybe through the first year and a half or so, after each clinic, we'd all go out to dinner at a Mexican restaurant there on University Avenue and talk about what we had seen and how we felt about it. It was actually an amazing period of time for those of us who were there, including the chief residents that volunteered and some of the medical students.
Now, I remember it well, and that was sort of our modus. We were trying to learn as much as we could, as fast as we could. Chris and I went out to local hospitals that had cases and interviewed and reviewed patients that were being treated there. And it really became a kind of support group because it was so difficult to watch these very ill young men often go into the hospital and not reemerge and so on. And so it was intense and a huge period of learning for us.
Maybe we should tell the story, Alan, about the regent of the university. Yes,
we were notified, I guess, through the hospital administration that there was a regent of the university, a lawyer from Los Angeles named
Andelson, Sheldon
Andelson. What's his first name though? I'm missing.
Sheldon.
And that's a name that's very similar to the kind of casino kingpin in Las Vegas, who was such a, and may still be, I forgot, still living, a Republican Party power broker. And so not the same person. This fellow came to us and Chris noticed that he had a nice business suit on, but sneakers. And we met him out near these kind of Quonset hut buildings that we were meeting, holding our evening clinics in, and started talking to him about the fact that we had this clinic, and we seemed to be the first one in the system to have a kind of dedicated HIV clinic. And so as he talked, you know, I could tell he was waiting for something. He said, "Well, where is it?" And Chris said, "Well, it's just over in that building from 6 to 9 every evening. So I'm sorry we don't have a building yet. You know, what can you do about that?" But it was, I think he expected at least an 8-story building of some kind.
Yeah, and you know, the story about him arriving on campus is interesting because I was having some trouble after the executive committee at the hospital approved the establishment of the clinic. There was some foot dragging on the part of some administrators to actually staffing the clinic with nurses and secretaries, and we couldn't open it. And in frustration, I reached out to the regent's office in Los Angeles and told him about this clinic, and I asked if he could intervene. So it created quite an uproar among the administration at UCSD to be contacted by a regent with no forewarning that this was coming. And after his visit, of course, we were able to open within 2 weeks. But shortly after that, I got a phone call from the dean's office requesting that I appear. The dean was Dr. Robert Petersdorf, a very famous infectious disease physician who had come to us from the University of Washington. And he was a rather gruff guy. And I remember going into his office as a young assistant professor and sat down, and he sat back in his chair and he said, "Young man, it's a free country. You can say and contact whomever you want, but I'd appreciate it in the future if you would give me a heads up if you're going to contact a regent."
Well, we were both so innocent. I didn't know that story, Chris. Thanks for telling me. But we were both so innocent. We had no idea, I think, you know, what a big deal it was to go directly to a regent.
I guess it's better to ask for forgiveness later. So
it was indeed.
So there were a few comments, and so Gigi still said we're still waiting for our building. Then that is true still. And Nettie had a quick question. She said, Dr. Mathews, thank you for sharing this story of the early days. Question is, you said the university was supportive of your initial idea of setting up a clinic for gay and lesbian health, which sounds very forward thinking for the time, and I'm impressed. But then you said there were no salary doctors, so that doesn't sound like support. Can you comment on that? Was it your preference to be volunteer, for example, perhaps to retain some autonomy or for some other reason?
Well, Laura and anybody who's been a clinic director will realize that it's always a struggle to get resources. It doesn't matter what the enterprise is, and especially if there's no substantial revenue associated with the clinic, which was obviously our case. And this was before Ryan White. There weren't any grants to fund it. I was working full-time at the VA outpatient clinic after my residency. So with no salary offer on the table, it really was voluntary on the part of everybody who worked there, except for the nurses and support staff.
Wow.
Within 1987, well, between 1985 and 1987, they funded a nurse practitioner for the clinic. And then in 1987, I switched over from the VA to UCSD, and then that was the first full-time salary support for a physician for the clinic.
Wow. So let's move on to question number 2. We're going to talk a little bit about the challenges in patient management. So the questions more specifically, what were the problems with hospice care and aid in dying? How did the recognition that HIV was not just a disease of gay white men evolve, and what impact did it have? Did the concept of equipoise differ from treating physicians, clinical researchers, and physicians who were doing both? And what was the UCSD experience with studies of the first antiretroviral drugs? So this one, I'll start with Chris.
Yeah, well, so these questions are very different, so maybe we should just take them one at a time.
Sure.
At the beginning, our experience reflected what was going on nationally, and the average life expectancy after a first visit in the Owen clinic was about 6 months. So there was death everywhere. And as the disease spread, more and more people were becoming visibly ill, bouncing in and out of the hospital, wasting, developing horribly disfiguring Kaposi's. And there were many suicides and attempted suicides. On the clinician side of things, the group of doctors who were caring for patients, and mind you, this was before internet and mostly before people had cell phones. We were trying to figure out how to best provide palliative care in this disastrous situation. And I remember one of our colleagues from UCSF, John Stansel, wrote an article about how to orchestrate the good death in this context. I personally had many patients either successfully suicide or unsuccessfully attempted. And I was deeply shaken by the experiences of having to go to a home or the hospital if they were brought in, and be there when they woke up and realized that they were actually worse off than they were previously. And requests for aid in dying started coming in. And unlike today, where this is an open discussion and actually legal in several jurisdictions to aid persons in that circumstance, this was illegal. And we all dealt with it in our own ways and privately. I remember one evening, I was in the hospital and a patient was close to death and wanted help with speeding things along. And I was uncomfortable directly doing anything other than sedation. And one of my colleagues, who happened to be my own personal physician, was writing notes at the nurses' station. And I consulted him and asked for his advice. And he said, well, what's the problem? Just do it. I was taken aback, actually. And a few months later, I learned that that physician himself had ended his life in a hotel in Mission Valley one Friday night. And it jarred many of us in the department. So in those days, San Diego Hospice was an enormous resource to us. Unfortunately, it was one of the greatest losses to the community when that facility closed. But they were providing wonderful, compassionate care to our patients, but they had a completely different philosophy about aid in dying. And we actually had a debate in the medical center auditorium one night between me and the medical director of hospice, because the book called Final Exit, which is still in print, had been published, and which was a sort of instruction manual for how to end your own life. So maybe I'll stop there. I don't know if Alan has any reflections about that particular issue.
Alan?
No, go, please proceed. I can speak to that. The second
Sure.
here, I already have mentioned that it seemed that people could sort of dismiss this as not an issue for them until this succession of groups began to accumulate, and soon people got the idea that this at least could be transmitted through blood, and most were, I think, much more fearful that it was contact or airborne. And so there was a lot of insistence that anybody who, had the disease should be really isolated and certainly not have contact with the general public and so on. So it was very isolating, I think, from that standpoint. And of course, in reaction to that, there was a lot of secrecy.
Great. Chris, do you want to tackle number 3?
Yeah, before that,
Sure.
I think we haven't really raised this issue of conspiracy theories, but maybe this is a good time because of the parallels with COVID. Alan, do you recall the episode of the Nobel laureate from Berkeley on the UC faculty who didn't believe that HIV was pathogenic?
Oh yes, and came and spoke with us in our auditorium. I can't nail it down. It was at least in the mid '80s. At some point, Peter Duisberg was his name,
Right.
and he had been a retrovirologist, but no one could really figure out why he failed to keep up with the developing evidence, which became more and more overwhelming, that this new virus was the cause of this. But the interesting thing, he was joined by another famous San Diegan who invented the PCR and whose name is escaping me at the moment. But this fellow and a kind of motley crew of various people joined a group of people who had credentials. In the case of Kary Mullis, the PCR inventor, had won the Nobel Prize, and they insisted that this couldn't be for real, that there were other issues. And one of the impacts of that really multiplied its effect was that Thabo Mbeki, the president of South Africa, kind of tuned into all this, and he was one of those guys who surfed the net on his own, I gather, and didn't listen to scientific advisors and so on, and decided that he was not going to bring the first antiretroviral drugs into South Africa, because they were obviously misdirected, because they were anti-HIV drugs.
Okay, so let me deal with this question about equipoise. I think probably most of you have heard the term. It's used in human subjects research, and especially with reference to clinical trials, as a criterion that can be used to decide when it is ethically justified to enroll people in trials that might be placebo controlled. But I'm thinking of it more as a broader concept. When the Owen Clinic was established and Alan returned from Great Britain, we had to make some decisions about whether the research component of our work would be housed within the same clinic as the care was provided. And there were models for both integration and separation. For example, the University of Miami, where Margaret Fischel was the lead investigator and care provider, had an integrated model. My feeling was that it was better to keep them distinct, but with a porosity between both enterprises that were synergistic. And I think over the years, there has been enormous synergy, as well as some tension, between the research programs that the university excelled in and the care programs that we also excelled in. Now, in thinking about preparing the discussion for today, I started remembering situations where the hat I wore as a personal physician for patients gave me a different perspective than I might have had or did have in other contexts as a clinical investigator. All of you that are clinicians realize, I'm sure, that when you enter the room to talk to a patient or agree to take responsibility for the care of the patient, they become your primary focus. And your role as an advocate, particularly in a disease like this, becomes critical. I think all you have to do is read the Screaming Room to see examples of physicians who assume that role and others who, for whatever reason, didn't seem to be able to provide the compassionate, committed care that was necessary. So let me just tell you about one case, again involving this same young patient, Peter Baum Lane, who had so many debilitating opportunistic complications. He had developed late in his course CMV retinitis, and ganciclovir, which at that point was called DHPG, was in very early clinical development. And one of our faculty was a lead investigator in the early clinical trials, phase 1 trials of that agent. And the Screaming Room goes through in detail the long waiting period to get Peter enrolled in this first trial. And he eventually got on it and had a dramatic response. Alan was involved in his care at that point, and his vision started to stabilize, and he was having some cognitive deficits, which we eventually realized was CMV encephalitis. But the trial ended and the drug was stopped. And in those days, there was no mechanism for compassionate use, and from a regulatory point of view. And so we had to watch him deteriorate after an initial improvement. The family, of course, was beside themselves. We were also extremely concerned, and I started calling the local investigator, the drug company, the FDA, trying to shake loose continued supply for a use which had already been shown to be effective in this one patient. And it all failed, and the patient deteriorated and eventually went on hospice care and died a few weeks later. So I just think perhaps later in the discussion, some of you would like to share your own opinions. I think with regard to the COVID epidemic and this question, it has to do with what are your responsibilities as a clinician when the availability of evidence-proven effective treatments is lacking, and there is uncertainty about how to proceed, and the stakes are enormously high in terms of mortality. What threshold do you need to cross to make a decision to use a drug off-label? Let me just give one other example. Many years later, we had a patient who was experiencing immune reconstitution inflammatory syndrome due to cryptococcal infection with massive cerebral cryptococcomas with mass effect. There was actually midline shift. and it was only controlled by dexamethasone in high doses. And this went on for 6 months. Amy Siddipati was his doctor. And I came across some articles in Clinical Infectious Diseases of few cases of people who had similar syndromes due to mycobacterial disease that were treated with TNF inhibitors. And so I contacted the author of one of these case reports and asked him his opinion about using it in another granulomatous infection. And he was skeptical at first, said there was no evidence, but was worth the try given the desperate situation we were in. And so Amy and I and Lalo met and agreed that we would try using adalimumab, Humira, in this one patient. And he had a dramatic response and was able to be tapered off the steroids. So I just mentioned this as one example of many that could be thought of, where you as the treating physician who are responsible for advocating for the patient can't always practice by an evidence-based medicine guideline. And so it can create some tensions. I know, for example, during the early days of COVID, because there were very limited therapeutics of any proven value and a lot of conjectural evidence with limited support, having to do with hydroxychloroquine, ivermectin, and other agents, and what we should be allowed to use to treat individual patients, and so on. So some of you may have opinions about that, but it's an old problem, I think, long antecedating HIV, but one that we all face as physicians.
Great. Thank you for that. I think for the sake of time, I'm going to move forward to our next section here. And this is more based on the questions based on the role of the Owen Clinic and the development of clinical and basic research. So what were some of the earliest efforts by UCSD to understand the disease, and what were the programs that evolved from these efforts? So I'll start with Alan.
Yes, I think we've already touched on the fact that from the start, as clinicians, we were trying to educate each other based on what we were seeing in the clinics. And, soon thereafter, we began to recognize that, and actually based on that first case I mentioned, the tremendous value of autopsies in these patients. And so we began to systematically review autopsies with the pathologists, and then with somebody discussing what new thing we might have learned from that particular case. And I think that really helped us to realize how weak our diagnostic methods were for a number of the opportunistic infections. And I wanted to mention that out of the Owen Clinic, I was able to assemble a cohort of about 100 gay men who we were following on a regular basis under state funding. And that group then served to help us start a number of projects that are still ongoing in many ways. First, we became part of the first AZT trial. And I did want to mention a very instructive sort of episode there. Doug Richmond and I sat down with the first two recipients here in San Diego, and because it was all new and so on, we wanted to be sure that and they understood and we understood, what was going on and the placebo nature of this study. And so the placebo controlled, that is. And so we talked it over. It was clear these guys knew what was happening. And then we handed them the bottles of their study drug, which of course was masked for whether it was AZT or placebo. And right in front of us, with no hesitation, they immediately opened the bottles, opened the capsules, and started tasting the contents of the capsules. So it taught me, in a desperate situation like that, and probably many others, people were going to try to unmask your masking. And so, I've ever since, been so aware that you have to be really careful. And, we eventually were able to measure, drugs in people's blood and so on, to be sure our placebo controls were not in fact on drug through sharing with other people and so on. So that program, of course, through the AIDS clinical trials group, evolved into an enormous and ongoing effort, that's been led by Doug and Connie Benson and Steve Spector and many others here at UCSD. And Steve then kind of evolved his own program and was a leader in the pediatric AIDS clinical trials group. Meanwhile, I had worked with, or discussed, I should say, with Igor Grant and Hamp Atkinson, this enormous amount of really severe dementia we were seeing in these early untreated patients. And they mobilized, and I was able to give them access then for testing of cognition and also for depression and so on. And we evolved a paper then describing what we thought was not only the severe end of this scale, but that there were a lot of people who could pass in clinic for perfectly okay, but were clearly showing on the objective cognitive tests problems. We published that, and this was about the time the military was beginning to worry about gay men in the military who would be infected and maybe affected by the virus, and they went on to take their pilots, and by that time we could do blood tests for the drug and basically ground all their HIV positive pilots, and that was made us pretty unpopular with the gay community for a little while, and then I think after a bit they began to realize, the leaders throughout the country, that this really was a problem, and they engaged in studies in a major way. So that was the beginning of the HNRP and all the associated studies.
On the clinic side, we had always had a commitment to documenting what we were observing in the care of patients. And so early on, we created sort of rudimentary databases, first in Excel, and then one of the young Owen Clinic faculty, right out of his residency, Jim LaBelle, had skills in programming, and we wrote a grant to the Robert Wood Johnson Foundation to fund a HIV-specific electronic medical record that Jim designed, and we used that for several years. and then moved on to a commercial product called Lab Tracker, which served us for many years. I'm sure those of you that have been in the clinic for quite a while remember those years. And then, of course, we migrated to Epic. Those initial efforts to document routine clinical and laboratory and administrative aspects of care, combined with annual searches of the National Death Index, allowed us to create a comprehensive resource for both clinical and translational research to identify patients for clinical trials, and allowed us to leverage that resource to participate in multi-institutional collaborations like the HIV Research Network through Johns Hopkins, and later through CNIX, which has brought in a lot of resources. So this has been, I think, a very positive interaction and synergistic aspect of both the research and clinical care in the clinic.
I think I just want to emphasize how Chris went off to UCLA and got further training in public health and research, and has really been a tremendous, I think, leader in using the clinics as a tool for clinical epidemiology, if you will, and then interventions of various kinds. And he's really a pioneer in this area.
And I would echo that. I think for honestly, both of you too, I think were very instrumental early on, and really, I think had a vision for how things needed to be. And I've always felt that the Owen Clinic has always been ahead of the time for everything, whether it's the EMR that we had many years ago, or whether it was these various subspecialty clinics that we would have that Chris would encourage us to develop. I think we were always a little bit ahead of the curve, and I think it's thanks to both of you too for your efforts. So, go ahead. Did you have
one other issue I wanted to say is that that Chris and I both, I think, had a strong desire to in some way broaden our impact and this knowledge that we'd acquired with such difficulty over this period of time. And so we were invited by the Navy to take a tour of a number of sites in Africa that they were interested in working with, and they had funding to train the military medical officers in these areas. Military, being important to our government for the stability of these countries, and also because these militaries were particularly heavily hit. And so Chris and I then were able to get some responsibilities in the PEPFAR program, myself in Ethiopia and him in South Africa, that I think helped us fulfill that drive to try to help Africa deal with this.
Great.
Yeah, and that also allowed us to bring over fellows and other faculty to have the experience of working in HIV in very challenging developing country settings.
So our last, we've got about 7 minutes, and so our last topic is about the effect of both epidemics and pandemic in regards to the effect on clinicians, providers, research to the general public. I think we've kind of touched on some of these issues, but I am curious, especially I think the last question about stigma, burnout in clinicians. And we've heard some of the stories I think you've kind of mentioned early on, but this one I guess I'll start with Chris on this one. I'll let you kind of choose whichever direction you want to go with it.
Yeah. Well, I think the ones that were most vulnerable to the stigma on the provider side were the nurses. I remember stories that some of our nurses would tell us, particularly the ones on the inpatient unit, how in the early days they found themselves shunned. The people that they used to gather with for lunch or breaks were avoiding them. And we gradually identified such a stellar group of compassionate nurses who basically volunteered to be on that unit and provided a safe haven for our patients when they were most vulnerable. I'm enormously grateful for every single one of them. And as you know, some of them, as they got older, migrated over to work in the Owen Clinic. On the physician side, yes, there were issues of burnout that would show up in various ways, sometimes with substance abuse, mental illness and challenges that were very difficult to sort out, not having the personal expertise myself. And those experiences actually led me to get involved with the Physician Wellbeing Committee and to learn a lot more about physician impairment and ways to identify it early and to support people. And the clinic itself, we had monthly potlucks at people's houses. We had our weekly staff meeting in which to help us deal with the grief of so much loss, we would pass around memorial cards that we would send to the families, and everybody would sign. Sometimes there were up to 8 deaths in a week. So we did the best we could, and it was an enormous relief in 1996 when the first protease inhibitors were licensed and the ball game really changed.
Alan?
Yes, I'd just like to indicate that while we've described as a situation of great duress for us and our patients early in this epidemic, the pace at which it grew was so much slower than the current COVID epidemic. And just a great thank you and appreciation to the responsiveness of UCSD and the faculty and the nurses and everybody else just jumping in and doing what had to be done 2 years ago. And I just, it just had so much more impact, I think, in terms of intensity of work and all that sort of thing, and the speed at which things changed in the COVID epidemic compared to HIV. I think that's one of the striking differences to me between the two epidemics.
Great. Well, we're, I think at the end, we've got about a minute or two. So, but I did want to just thank both of you for your stories and for sharing about your experience. I think there's a lot, obviously, that we can certainly learn from what you both have experienced. So I wanted to open it up for questions, and so I'll go ahead and stop sharing here, and I'll open it up to just see if there are any other reflections or questions that people have. I do see in the chat pod, Will Toporov had talked a little bit about having a Duisburg patient that ended up, unfortunately, very sick, and see here from Jeff Taylor, talked a little bit about his experience of being here in San Diego and being alive today as a result. And then Nettie mentioning here about how disheartening when medical providers give to the community, but then fear still allows people to embrace stigma, not remotely the same scale, but during early COVID days, people avoided doctors and nurses, et cetera. And so many docs found this very hard on their kids and being socially isolated. So so I will stop there and just see if there are anyone wanted to unmute themselves to ask a question or make a comment.
Really 5 or 6 years ago, so his impact was still being felt.
Thanks, Will.
It's been a great decade for conspiracy theories, I think.
Yes. All right. Well, I think we'll go ahead and end today's session, but certainly we'd like to thank both of you, Chris and Alan, for being here and certainly sharing a lot of these important experiences. And I think it gives all of us who are currently still in care, I think a perspective that sometimes I don't think we always remember, and really so far that we've come along, and I've certainly have benefited and from our interactions, and I want to thank you both from the bottom of my heart for being here and for doing all you've done for us. So thank you very much.
Thank you, Dan.
Thank you.
Thanks. Bye-bye.
All right.
Bye.
Have a good weekend.